Okay, good afternoon, y'all. I'm sorry that you're getting this by Zoom, but anyway, this is something, hopefully all of this is pretty much in a review for y'all. I know that Dr. Huff said that she had gone over sickle cell a lot, so I just kind of want to go over it with the pediatric facts into it a little more. But we're going to start off with the hematologic function. And the assessment of the hematologic function obviously is the first and foremost is looking at the whole child and making sure, doing the first thing we usually do when we're looking for the hematologic function is look at the blood. So we're going to look at the CBC. We're going to look at the history and assessment. We want to look at the child's energy level, and we talked a lot about that with cardiac. So child's energy level will tell us a lot. And then we also want to see the growth patterns. Do they have enough? Are they slow to grow? Are they having a hard time? Are they failure to thrive? Things like that. Sometimes it means that they don't have enough iron. Sometimes it means it's a cardiac issue, so the heart's not pumping. But if it's not a heart issue, maybe it's the fact that the child doesn't have enough iron in their blood, and so that's what's causing the growth patterns. We all know that the hematologic function, the red blood cells are responsible for transporting the oxygen to other cells in the body, and they transport food and waste, hormones, all that kind of stuff. And we have to have a lot of good red blood cells to function for the immune system to fight it off. So that's why it's very important. That's why kids who have a very low immune system, and we'll take maybe some sickle cell kids when they have low immune systems and stuff. We have to worry about them fighting off infections because maybe they have a low white blood cell count. Obviously, when we're talking about chemotherapy and we talk about it lowers their white blood cell count, well, when they lower the white blood cell count, it allows them to be more infected. So making sure that the hematologic function, making sure you have plenty of red blood cells and white blood cells, and that enough oxygen transporting around will keep us all healthy. Okay, so let's talk about the red blood cells. So we're going to talk about anemia, and anemia is the most common hematologic disorder in children. It's a decreased number of red blood cells and hemoglobin. And I tell the kids that it's kind of like, think about a train, and the anemia, the red blood cells is the engine of the train, and the oxygen is like the caboose of the train. And if you don't have a lot of the engine, which is the iron, the red blood cells, then you're not going to have a lot of cabooses. And so I tell the children, if they want to, especially my athletes, if they want to run faster and do faster, if they're very good studious kids and they want to make higher grades and better grades, you have to have a lot of those engines, which are the hemoglobin, to be able to have a lot of those cabooses, which are the oxygen. And you can't run fast, you can't think fast, you can't do anything fast if you don't have a lot of oxygen. And that train is going all over your body. So if that caboose can't be attached to that train, you're not going to have a lot of oxygen, and therefore not a lot of oxygen, not a lot of boost to your system, you're going to fall behind, not be able to keep up with others, you may not be able to think very good, that kind of stuff. Classifications of anemias. So we have the etiology and the morphology. So we're just talking about the depletion of it or the characteristics of the shapes of the red blood cells. Sometimes clinical manifestations, again, that they can cause cyanosis, growth retardation, cardiac involvement, lots of different things can be going on. And we evaluate those by looking at the CBC, particularly the red blood cell count, the hemoglobin, and the hematocrit. There's lots of other tests to be looking for that. For instance, a lot of times in the NICU, you'll be looking at reticulocyte counts. They call it a retic count, R-E-C-T. And if a reticulocyte count lets us know how quick the babies are making red blood cells. And if the reticulocyte count is very high, then we know that they're making a lot of red blood cells, so maybe we don't have to transfuse quite as soon. If the reticulocyte count is low, then we know we might go ahead and transfuse them because they're not making enough reticulocytes, and so their hemoglobin and hematocrit is going to be low for a while. Anemia, obviously, we're going to treat the underlying cause as far as transfusions if we need it, especially after a hemorrhage. Nutritional interventions and supports, particularly iron. We're going to give iron replacement supplements. And then supportive care would be IV fluids, oxygen, and bed rest so that they're not using up all of the extra oxygen just to move around. Nursing considerations will be preparing the family and the children for lab tests. Most of the kids who are anemic are used to having their fingers stuck or having their blood drawn. And then just decreasing the oxygen demands. This is not a good time for those kids to go out and do a triathlon if they're anemic or if they're having issues with anemia. Blood transfusion therapy. Yes, we do give blood transfusions to kids, particularly in the NICU. But what we try to do in the NICU is in one blood transfusion, we divide those blood transfusions into 4 different, we call them PD packs. So one transfusion is divided into 4 packs, and we try to make sure that that baby gets just one of those 4 packs, and then they'll get the second of the pack, and the third of the pack, and the fourth of the pack, so that they're only exposed to one person. We always make sure that when we are giving for nurses, we make sure when we are giving blood transfusion, we obviously monitor their vital signs ahead of time. We always check, 2 people check the bag and making sure it's what it's supposed to be. We use a filter needle or a blood filter when giving it. We want to make sure we use the blood within 30 minutes. And then if we infuse, usually the maximum time we infuse blood over is just 4 hours. Transfusion reactions. Occasionally kids don't have as many reactions as adults, but they can have reactions. And there's some nursing alerts about some of the transfusion reactions. I think there's a whole chart about the difference in reactions where an air emboli versus allergic reactions. Nursing responsibility, making sure that we're giving the correct donor blood and the right type of blood and transfusing it slowly, and then watching the patient. We also, if they're having any transfusion signs or symptoms or reactions, we want to stop the infusion immediately and notify the provider. Like I said, most babies don't usually have that. That would be more with older kids, particularly kids like leukemia and stuff, where we have to do lots of transfusions. So sometimes we can have iron deficiency anemia caused by inadequate diet supply. Y'all have heard me talk about that you have to be really careful how, especially maybe indigent moms or dads or families are making up the formula. So we try to give babies high fortified formulas. But if they're trying to spread out the formula because maybe they're running out, or maybe they're using, if they're on WIC and they're using some formula to go for 2 or 3 kids, not just for one, sometimes they'll put twice as much water, which means they have half of the iron that they need. So we need to make sure that if babies are coming in with anemia, that we make sure the parents understand how important it is for them to take the formula like it's suggested. We also use iron fortified cereals. This is like rice cereal and oatmeal cereal, those kind of things. We start babies on those around 4 months of age. We know that preemies get special care formula, and we'll give them like Sim Special Care 24 calorie, 20 calorie. We'll increase the calories in it. And we also know that, and we found a lot of times I'll have those toddlers, particularly those toddlers that maybe 18 months to 2 years of age, and they're still taking 3 or 4 bottles of milk a day. Well, besides the fact that they're rotting their teeth out, the excessive milk intake is decreasing the amount of food they would take. And so they will have excessive milk intake, iron deficiency anemia, just because they're not eating right. They're just only taking milk, and milk doesn't have a lot of iron in it. The other thing is adolescents. Of course, all adolescents have problems with eating habits. A lot of adolescents don't eat meat. This is when they like to try out, I'm a vegan, and nobody else in the family is vegan. So the mom doesn't know what to do. So the kid says, I don't eat meat. And so the mom says, okay. So every time they have meat, they just give them a salad, or they get to eat something else. So sometimes it's important that we explain to them that if you're not going to eat meat, you have to have a meat substitute. You need to have eggs and dry beans and peanut butter and that kind of stuff. And sometimes kids aren't crazy about those, the substitutes. So again, the pathophysiology is a microcytic anemia. So it's just, there's not enough iron in the blood. Therapeutic, we're going to give them iron sources and food. And the best thing we can do as management is prevent this. There's a YouTube video I would really like for y'all to watch. It's really good on sickle cell. It explains it so good. It explained it to me so good. It's very, very easy to explain. Once I watched that video, it was so much easier for me to explain it to my patients. So sickle cell anemia is primarily occurs in African Americans. It's 1 in 375 infants born in the United States. 1 in 12 have a sickle cell trait. So if they have the trait, they do not necessarily have the disease, or they don't have the disease, but they have a trait. So if 2 people get together with a trait, then there's an increased incidence of their babies having it. Occasionally people with Mediterranean descent can have it, and also people with South America, Arabian, or Eastern Indian. And we know that the etiology of sickle cell in the Arab world, where malaria is common, individuals with sickle cell traits have a higher tendency for survival than those without the trait. I thought that was really interesting. So there's types of sickle cell crisis. So we can have a splenic sequestration, life-threatening crisis, and this is where blood is pooling in the spleen. The signs are they have profound anemia, hypovolemic, and shock, and this usually happens in younger kids. Eventually, sometimes kids, even with sickle cell, will have to have their spleen removed as they get older. So the big things that you need to know after you've watched that video about sickle cell is hypoxia and low oxygen triggers a crisis. So we know that the cells become very sickle shaped and then they stick together. And when they stick together, that's what causes the clot, if you will. And that's what causes the problem. It's just like the sickling of the red blood cells or the clot in the red blood cells. Wherever that clot is cutting off blood supply to the rest of that body. So say it's in the hand, then the fingers are going to get blue. They're going to be hurting so bad. It is a very, very, very painful problem with sickle cell when they start sickling, when they start triggering a crisis. So a couple of things you need to do. First and foremost, we need hydration, hydration, hydration. Just think about if that river is dammed up, the more water we can get through and get around and get to the rest of the body, the better off they're going to be. So hydration is going to be one of your very first things. We need to promote hemodilution on that. We need to promote circulation. So we need hydration. And then also we need to make sure that we get them some pain meds. We want to get that fever down, and we want to get them on some oxygen. Oxygen is going to be, because oxygen, the body's needing oxygen transport, but we got to get them. So hydration is going to be first, then followed by oxygen and pain meds. This is just the whole body right there, and what parts of the body can be affected by sickle cell. And it's pretty much head to toe. Obviously the worst thing, or I guess one of the worst things, could be a stroke, paralysis, and death. Remember this, no other very, 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 let's say not, I won't say no, but very few other disorders we have to worry about strokes in kids. But sickle cell, that's what it is. Such a it's a horrible, horrible disease, and it causes such horrible things. Once it's caused a stroke, sometimes the brain can figure out how to rewire itself, but once it's caused blindness, that blindness doesn't come back, and it's really, really hard. These babies have a lot to deal with. Obviously, they frequently have splenomegalia, so the no contact sports for them. They really need to reserve their oxygen supply. They can go into some major, major pain. Ulcers or cuts and things like that are hard to heal because they're not having good circulation. So this is just it's a horrible disease. So the pathophysiology of it will be that partial or part of the hemoglobin is now a sickle shaped cell. So it's not every one of not all hemoglobin, but a lot of the hemoglobins are this elongated sickle shape. Hopefully if you watch that video, it'll show you how it just sticks together, and it just causes this major stopping of the blood flow. And hypoxia causes it. When they get hypoxic, it causes the sickling, and it just gets worse and worse and worse, which goes into very, very, very painful. And we talked about that. Precipitating factors, what causes these bodies or what causes the body to automatically start sickling, if you will? It can be anything from the need of oxygen. Okay, well, when do we need oxygen? I need oxygen when I'm walking up steps. So the need of oxygen can just be daily routines almost. Trauma, infection, fever, physical, emotional stress, dehydration, Can you tell me one time that a child in their lives is not going to have some of that? They're going to be emotionally stressed or physically stressed or have a fever or have an infection sometime in their life. And when they go through that and they start having the sickling and it gets so painful, it is just really bad. And then also the hypoxia can be from high altitude, poorly pressurized airplanes. I mean, just so much that this family has to think about going anywhere to do anything. Acute exacerbations vary in severity. Most of them are very painful episodes. It can cause the stasis of blood and the clumping, which causes ischemia, which can cause infarction, which can cause the stroke. And like I said, it's just very, very painful. They can have, if the spleen's involved, then lots of times the kids will have to have the spleen out, which just goes even worse. Death can occur within hours. So I never want you to take it lightly if you have a child that comes into the ER or to the doctor's office, to the walk-in clinic, or even just maybe just to have a surgery. Maybe they need tubes in their ears or something like that. You don't take it lightly when you have a sickle cell baby. Sometimes these babies, it's triggered so much by infection. Occasionally, I know we had a baby that I took care of, and probably when he was, I want to say about 3, and he went to the sickle cell clinic at Grady. Phenomenal clinic that we can send our patients to. But he lived in Hartwell, Georgia. Well, how convenient was it for that mom to get her baby to Grady Hospital once or twice a week, or even once or twice a month? That was at least hour and a half, probably 2-hour trip down there and 2-hour trip back. So it was hard. It's hard for her to go down there. But they ended up putting him on. He was on penicillin, and he just took PenVK every day. And what they were trying to do was just to keep him from getting infected. The prognosis of sickle cell, there's no cure, except possibly they're starting to have some good cure rates, or some good, showing some good things from bone marrow transplants, supportive care, and trying to prevent any sickling episodes, frequent bacterial infections. So we've got to try to keep from doing that. So a lot of times we put these kids on, like I said, antibiotics, and you know how much I hate antibiotics, but I hate sickle cell even worse. Strokes in 5 to 10% of the children with this disease. And so a lot of times they can be neurodevelopmentally delayed or cognitively delayed. It's also going to be a thing that sometimes they don't think about. If a child, or if a baby, say a 1-2-year-old, has had a sickle cell episode, we need to get OT, PT, even speech involved, so that we can help teach the body neurologically how to retransmit or reroute around where the stroke was. So maybe these kids can still be very active in school and in the rest of their life. Another thing, kids can also have what's called acute chest syndrome. It's similar to pneumonia. Again, it's just the sickle cell is affecting in the lungs. I guess you can tell by now, sickle cell is a horrible, horrible, horrible disease. And if they have the acute chest syndrome, we do aggressive treatment for infections. Again, that's the little boy we were doing the prophylactic oral penicillin from 2 months to 5 years of age, just to try to keep him from having an acute chest syndrome. And we monitor the reticulocytes counts frequently. They give blood transfusions. I know the little boy that, like I said, was on the antibiotic, he would go to Grady once a month for transfusions, and he got a blood transfusion every month. So he was just prepared to sit down there, and he took it like a little man. He was like, 3-4 years old, and he took it like a little man. Promoting treatment, position comfort, range of motion, making sure that they don't get very stiff, warm compresses, and rest and gentle massage. Okay, another video, and this is about a completely different one. I want you to see Isaac's story. And it kind of puts it, to me, it kind of puts it home when you can put a person's name with it. But Isaac has continued to grow and do well, and he's able to take care of himself. And you can see how he's kind of dealt with his with his disease, and he's doing well with it. So watch Isaac, and remember hydration, hydration, hydration. Okay, thalassemia is the next inherited blood disorder of hemoglobin synthesis. It's classified by hemoglobin chain affected by amount of the hemoglobin. It's autosomal recessive and varying. Both parents must be the carrier. Both parents must be the carriers to have the offspring with the disease. This is another story. This is a little one that you can, I would love for y'all to watch this. He talks about how he knows he has thalassemia, and you will watch him, and he gets stuck, and his mother does his intervention every night, and he takes it. It's amazing what kids can get used to. So thalassemia as anemia results from the defective synthesis of hemoglobin, and it structurally impaired red blood cells. And what happens is it has a shortened life of red blood cells. So the red blood cells don't last as long. So they have to have something to help them last a little longer, because this causes chronic hypoxia, which will then cause headaches, irritability, everything. If you would have low hemoglobins, intolerance, anorexia, can't keep up with their peers. It's usually detected in infancy and toddlerhood because they're very, very pale, they're failure to thrive, they have a hepatosplenomegaly, and they'll start having severe anemia. You first time you bring those babies in, we start checking their hemoglobins at a year of age, maybe 6 months of age. If they're looking really, really pale, failure to thrive even before that. But we check it, we make sure that what's going on, we put them on iron supplements, we check it again, it's still not coming up, we check it again, we send them to hematology. So there's 2 different types of thalassemia. Y'all don't need to know about the 2 different types, just know they're 2 different types in case that was ever, you were working on hematology unit. But there are 2 different types of thalassemia. There's alpha and there's beta, and beta is the most common. So beta thalassemia even goes down from there. Again, you don't need to know the 4 different types of thalassemia. I want you to know that thalassemia is divided into alpha and beta, and then thalassemia beta, which is the most common, is then broken down into 4 different types. You don't need to know different ones, but you can be an asymptomatic silent carrier. So there can be people who have thalassemia who don't realize they have thalassemia, and that's kind of what you need to kind of get out of this, that if you have a child with it, you need to go back to the parents and look at, because obviously they're at least carriers, or they may have the trait. So it's kind of one of those things just for genetic testing that you would need to know. If you're working in hematology, you need to know what type of thalassemia, because you need to know what to expect, whether it's the moderate or the severe, that kind of stuff. If they're going to require transfusions, if it's going to be this, if it's going to be that. But for you, for nursing school, you just know that thalassemia is divided between 2 traits, alpha and beta is divided into 4 different more types. Thalassemias, a lot of times they present with the Eastern descendancy, but not always. And if you look at that video, this little boy is just a little Caucasian little boy who has a sister who wants to be in the video with him. So it doesn't always. So what I'm saying is we have these pictures of what we think these kids, or what the book says these kids should look like, and they don't always. The diagnosis is by hemoglobin electrophoresis. The red blood cell change is often seen by 6 weeks of age, and again, they're usually going to present with anemia and failure to thrive. Medical management, these kids get lots and lots of blood transfusions. We treat them with iron chelating drugs. The iron binds with the iron chelating drugs, binds with the iron, and it allows them to not have the anemia as much. Remember, anytime we're giving iron chelating drugs, whether it be the IV ones or just giving oral iron, we always want to give it with vitamin C. Vitamin C. So if we're giving the iron, we want to give it with vitamin C. And that's with any baby who has taken iron. They need to be taking it with some vitamin C, orange juice being usually what we use. Nursing management, we want to observe for complications of transfusions. We talked about transfusions. Support to the family, lots of genetic counseling. We need to figure out kind of where go backwards and figure out the parents, if they were silent carriers or if they just had the trait. if there's a chance, if they can, you know, siblings, that kind of stuff. And then we want to make sure that we can hopefully prevent as much as possible. We know these kids probably going to have some growth retardation. They may just be very small. They may have delayed or absent secondary sex characteristics. Again, each one of the prognosis is just according to how bad it is. We never know for sure. They do know that bone marrow transplants are a potential cure. And again, we talked about the prognosis. So we're going to talk about the defects in hemostasis. I know y'all have heard me talk about, when we talked about cystic fibrosis, the hemophilias with Camp-1 clot. So the hemophilias always have a special part in my heart too, because they're just regular kids too, just trying to deal with this horrible disorder that they've been dealt with. It's a group of hereditary bleeding disorders that result from deficiencies of clotting factors. So with hemophilias, we have to worry about them. So, you know, with the cystic fibrosis, we were so worried about them not gaining weight and them losing weight or getting infected. Hemophilias, we were worried about them falling, bruising, getting cut. I stayed in the cabin with the cystic fibrosis kids, but I felt like with the hemophilias, I was walking around trying to keep them in like a bubble. And then I was trying to pour calories down my cystic fibrosis kids. So hemophilia, there's two different types of classifications. There's classic hemophilia, which is the deficiency of factor VIII, and then hemophilia B, which also is known as Christmas disease, and it's a deficiency of factor IX. The hemophilia A, deficiency of factor VIII, is 80% of the cases. So it's much more common and occurs in 1 in 5,000 males. It's an X-linked recessive trait. Males are affected, females may be the carriers. The degree of bleeding depends upon the amount of clotting factor, and it's and the severity of the injury. So if it's a bad fall, they may have much more bleeding than if it's just a little knock. If you've ever seen a boy's shins, you know that there's always bruises on it. So these have a lot of bruises. Up to 1/3 of the cases have no known family history. So sometimes we can't figure out why. I guess you'll hear me say that a lot of times, why babies why we have premature deliveries, why somebody has this, why it happens to other people. Sometimes we just don't know why. Hemophilia manifestations, bleeding tendencies range from mild to severe. Symptoms usually don't occur until about 6 months of age. Usually it's from some fall. And then I'll usually have parents say, they are bruising really bad. It wasn't that bad a fall. They just fell down. They just did this. They just did that. And they just start having lots and lots of bruises. Then they'll start having some hemoarthrosis, which they have bleeding into the joints, the knees, the elbows. So their knees or their elbows or their joints get really big and gets swollen, and they're unable to walk. And again, this is maybe when they start walking, like 9, 10 months of age, and we're like, something's going on. Ecchymosis, they have bruises everywhere. Epistasis, a lot of times the babies won't have epistasis quite as much. The epistasis I really have to worry about with a little bit older, and bleeding after procedures. So just think about, you know, these kids want the tooth fairy to come see them too, so they're pulling their teeth out and it bleeds and bleeds and bleeds and bleeds and bleeds. So we really have to worry about that. Tooth extractions, minor surgeries. Again, bleeding in the neck and chest, we have to worry about mouth compromises and airway compromises. I guess it's not, y'all figured this out, but they can't have any contact sports. So you try to make sure that they can be, you know, normal. So we help them find a sport. And for a while, it was like, because sometimes in the smaller counties, we're kind of limited. A lot of times, you know, swimming would be okay, no diving, but swimming would be okay. But a lot of times they don't have swim teams around. So it's kind of hard sometimes to find a sport good for them or a sport that they can do. Golf has seemed to be okay. That's about all I can think of. You know, it's just hard to come up with something. And these kids, they want to be normal. They want to be like all kids. Kids just want to be kids. This can be diagnosed through amniocentesis if the parents have genetic testing and if they have good prenatal care and if we know this. A lot of ifs. Diagnosis based on the labs, the history, exam. They will have a low factor VIII or factor IX with a prolonged PTT. They'll have a normal platelet count, a normal PT, and a normal fibrinogen. So most of the time it's a low factor VIII because that's the most common in a prolonged PTT. Clinical therapy, like I said, it can be diagnosed by amniocentesis. Medical management is going to be that they're going to get what's called DDAVP, and that's the little boys getting that. No, the boys will get that. It's usually by IV. And what the DDAVP, it causes 2 to 4 times increase in the factor VIII factor. And so it will cause them to make more factor VIII, which will replace the missing clotting factors. Occasionally they do transfusions at home. The parents have gotten very good at this. The parents can do the factor VIII a lot of times. They will have to do factor VIII quickly after major or some hemorrhages. If they start having hemorrhaging, they'll have to do the factor VIII. Historically, kids who had hemophilia did not live long because one big fall, of course we didn't know about it in genetic testing and stuff, so one big fall and they would just bleed to death and we couldn't figure out what was going on. So now these kids live to be mild to moderate lives. They live near normal lives. They just obviously can't do any contact sport things as long as short of them being in a horrible car crash or major injury or something like that. They do fine. Interventions, we want to make sure we prevent the bleeding. Obviously, it's very important that they have good identification, especially like teenagers. Can you imagine how scary a mom letting her hemophilia child, her 16-year-old, start driving is? Making sure that they have good, putting the bracelet on. And let me tell you, no 16-year-old wants to wear a bracelet that says I'm a hemophilia. But making sure that they have some type of something to show them how that if they had a wreck, quickly, you need to start assuming that they are bleeding from internally. Teaching the boys how to shave with electric razors and not the other type of razors. Just if they have any superficial bleeding, just a hangnail to make sure that you use ice and 15 minutes of pressure and that kind of stuff. I mean, it's just a lot of little things. I mean, who thinks that they could bleed to death from a hangnail or just a paper cut? But you just have to take it really seriously. And sometimes we, as people who don't have it, don't understand what these people have to go through and what these parents have to think of. And they're constantly thinking ahead of, I need to make sure that I have an ice pack and gauze and stuff with me. It's just a lot for parents and kids to have to deal with. Like I said, most of them are doing well. We do close interventions. So once the bleeding is stopped, when they have the bleeding, obviously we elevate, immobilize, and ice. Once the bleeding has stopped, we want to do some range of motion to prevent some contractures. PT is their best friend because PT is going to keep them involved. A lot of times they can do like some, you don't want to say long distance running because they really don't need to do long distance because of the oxygen supply, even though it really, as long as it's high enough, it should be okay. But PT, get them some good workouts. And obesity is not going to be their friend because we need to minimize the stress on those joints. So getting them some good exercises, whether it be like water is really good for them. It doesn't put any stress on the joints. So swimming's good, water exercises, water aerobics, that kind of stuff. Manifestations, y'all have gotten this by now. Bruising, epistasis, gingival bleeding, excessive bleeding, menorrhea, because there are a few cases where the female has had, and it's a different type of hemophilia. And we did have actually a few girls at Camp Wannaclot a few girls that were at Camp Wannaclot, and they would have some menstruation. It's not the classic one. It tends to be more the Christmas disease, where it's the 15%. But if they have hemophilia, their period is horrible. So just being aware of that. It's very rare, but I just want to put it on there so that it can happen, but it's rare. Again, the diagnosis is going to be with a decreased von Willebrand factor. Their PTT may be normal, the platelets may be normal, but they're going to have a prolonged bleeding time. Von Willebrand disease is a hereditary bleeding disorder, kind of like